Hi, and welcome to today's webinar titled How We Manage Severe Asthma in 2025. My name's Dr. Pujan Patel. I'm a consultant in respiratory medicine here at the Royal Brompton Hospital in London. And here I have the pleasure of looking after some really challenging and tricky cases of patients with severe asthma alongside my team at one of the UK's largest standalone severe asthma centres. These are the customary disclosures. And so over the next 45 minutes or so, I just thought it'd be nice to take you through where we are in the general landscape with regards to severe asthma as it currently stands. I won't be going over the basics of asthma or asthma management in general. And that's primarily driven by the fact that our bread and butter and our day-to-day practice very much revolves around looking after severe asthma patients, and actually that's where the largest amount of growth and development and change has really occurred in management over the years. And then go into more practical elements of who to refer, when to refer those patients, and obviously why you should consider referring them, because today's webinar is very much directed at our colleagues in primary and secondary care who may not be as familiar with the changes and dramatic, transformative things that have been happening in the severe asthma space, particularly with regards to add-on therapies such as monoclonal biologics. And so I will spend the latter half of the talk going into and delving into those management structures in more detail. So as I said, to start with, it'd be helpful to explain what it is that we mean by severe asthma. And if we take a step back and look at least the UK's population, here you can see that some of the older estimates have a population of severe asthma being around 5.4 million in the UK. And actually, when we look at more recent data from Asthma and Lung UK, they estimate that the prevalence is probably closer to 7.2 million, of which the majority or a large proportion are adults. And within that population of patients with asthma, what severe asthma really entails is only roughly about 5% of those patients. So as you can see in this blue circle here, we are talking only about a very small proportion of patients with asthma. However, as you'll subsequently see, these are patients that have a high degree of multimorbidity and certainly need a little bit more attention. So if we take a step back and again and analyze what it is that we're talking about, it was about 10 or so years ago that we really found and formulated a formal definition of what severe asthma really means, and that this European Respiratory Society collaborative with the American Thoracic Society, that was led by one of our own colleagues here at the Brompton, Professor Fan Chung, on the definition of severe asthma, really highlighted what it is that we're talking about. So we're talking about patients who have asthma who are on high dose inhaled corticosteroids plus a long-acting beta agonist or some second controller, but despite being on that therapy, are still requiring repeated bursts of oral corticosteroids, or in fact require maintenance, so daily oral corticosteroids, in order to control their asthma. And the measures that we kind of use to define control can be questionnaires such as the asthma control test or asthma control questionnaire or asthma control test. Another surrogate that we would use is how often a patient has required systemic oral corticosteroids, and a number of courses of 2 or more within a 12-month period is enough really to define a patient that has severe asthma. Obviously, if they've been in ITU or they've been they have very severe airflow limitation, that would also categorize them as having uncontrolled asthma under that umbrella of severe asthma. So as I said, it's a very small proportion of patients that we're talking about, and here we can see that in this Dutch study from nearly again 10 years ago, it was quite nicely depicted that what we're really talking about is not patients who have uncontrolled comorbidities or have poor adherence to their inhalers, because we all know how common that is, or have other explanations for why their symptoms are in control. But in fact, what we are talking about are patients who have optimized their inhaler adherence and their technique, and despite having comorbidities optimized, are still continuing to require bursts of oral corticosteroids to control, suppress their asthma condition. So that majority in this Dutch study was just below 5%, but in other studies, you'll see that it can be up to nearly 10% as well. And why is it that we pay so much attention or potentially need to focus in on these patients? And I think you can see quite clearly here that when you compare healthcare utility and healthcare costs that go into looking after patients with asthma versus those patients that have severe uncontrolled asthma, you can see the stark difference in the amount of healthcare cost that goes into patients with severe asthma and how much they require. And a big chunk of this comes from medication costs. There's also an understandable and expected increase in hospital admissions and appointments, but the bulk and the majority comes from medication costs. So why might that be? And the reality is that when you treat asthma or asthma attacks, you absolutely end up prescribing courses of steroids repeatedly. And as we know, steroids repeatedly have significant consequences. And you can see quite clearly here from work that came from colleagues in Australia that patients with severe asthma also carry a number of comorbidities, some of which are not directly related to steroid use and others which are. And you can see here, obesity is a clear and obvious one that can relate to excessive oral corticosteroid requirement. And if you're more obese, you're more likely to have uncontrolled reflux. You're more likely also to develop cardiac and metabolic diseases and other things such as sleep apnea. And so all of these things can be tied to either a combination of excessive oral corticosteroid use and also their underlying airways disease, which can manifest certainly in the nasal passages with rhinosinusitis or nasal polyps, and can be associated with other lung conditions also. So as I said, in order to control and manage these conditions, you would then need to be taking other medications, which obviously will translate into higher medication costs and healthcare utilization. Now, as I mentioned, we all know that oral corticosteroids come with a price. And it was really only after I started repeatedly seeing patients who have been harmed, damaged, destroyed by oral corticosteroids again and again and again that that point became very clear and evident. We all learn in medical school that all the things that you can see listed in the adverse events here on the left are associated with significant oral corticosteroid use. But the real question here is how much oral corticosteroid use can start to increase the chance of you developing these adverse effects. And I think David Price did a wonderful job in 2018 when he published this work that looked at UK-based historical matched cohorts of patients who are who had asthma and had received systemic oral corticosteroids over a period of roughly about 8 years, and he directly compared them to patients with asthma who did not receive any oral corticosteroids. And what he's able to demonstrate to us here is what the impact of cumulative, so repeated courses of oral corticosteroids can do in terms of increasing the risk of adverse effects. And although this looks like a busy chart, it's quite easy to comprehend when I take you through this, because if you focus your eyes on the green dots to start with, the green dots represent a total steroid exposure, a cumulative total steroid exposure within the time frame of the study of 0.5 to 1 gram. Now, if you ask yourself how much you prescribe to a patient with asthma having an attack, you typically would prescribe anywhere between 30 and 40 milligrams for a period of about 5 days. 4 courses of that treatment strategy will put you in this green box, in the green circle, sorry. And as you can see, the green dots all have a significant propensity towards an increase in all these significant adverse effects. And the more oral corticosteroid exposure you accumulate, the higher these green dots are. So it's not satisfactory to simply reflect on the last 12 months and ask the patient or look at your records and say, well, they've only had 1 or 2 courses of steroids this year, but they had 4 the previous year, so they must be getting better. The reality is the harm has already begun, and the harm is already built up from after just having 4 simple courses of oral corticosteroids across a lifetime. So as that increases, you can see that every single one of these risk factors starts to develop in an incredibly detrimental manner. Now that's repeated courses, and you will have all come across patients who are on maintenance oral corticosteroids for management of their severe asthma. Because as I said in the previous slides, the definition of someone who has severe asthma is those who are already on maximum inhaled therapy, but are yet uncontrolled and requiring oral corticosteroids. And this study from Korea looked at again, population-based matched cohorts of men and women over the age of 18 between 2005 and 2015, and demonstrated quite clearly to us that when you compare patients with asthma who are not on maintenance oral corticosteroids, which is this green line up here, against those patients who are on 5.5 or more milligrams of prednisolone daily, those in the red line, those patients have a considerably lower survival rate and chance of survival, which is directly in proportion with their mortality rate. So you can clearly see the harms that we are exposing patients to when they are left on maintenance oral corticosteroids. And up until a decade ago, we really didn't have any other option or choice. So this was very much the fate and the trajectory of patients with severe asthma. And this is what we mean when we're talking about what severe asthma is. It's patients that fall into this category. Now, when we look at the definitions of how we define asthma, they've also evolved and changed over time because our understanding of what's happening pathophysiologically within the airways and within the systemic manifestations of asthma has really changed. And as you can see, the Global Initiative for Asthma, who produce some very helpful recommendations every year, have highlighted that asthma is very much a heterogeneous disease, and that really represents the change in our understanding, but also the variety with which 2 patients who have severe asthma can present, and they can present very differently, which makes it somewhat more challenging to assess, but also forces us to take a more holistic approach at trying to understand all the various elements that could be a manifestation of their asthma. Now, in order to just give you a snapshot of where we are and how our understanding of asthma has evolved, I want to take you through a little bit of a brief touch on immunology, but without giving you an immunology lecture or trying to overwhelm you with all the different cytokines and cells. But broadly speaking, our historic understanding or our historic perception of asthma was very much binary to start with. So we define asthma as being allergic or non-allergic and or extrinsic and intrinsic in the most historical sense, whereby the premise was that allergens up here within the airway would come in contact with the airway epithelial cells, and between the airway epithelial cells there would be dendritic cells who have processes that essentially sense, attach, bind and process the allergens that they were exposed to, and they would then present them to cells within the immune system, such as naive T cells that would process them, and actually that would lead to the downstream activation of type 2 helper cells. And as you can see down here in the green cells, once activated, type 2 helper cells have been understood to produce a number of cytokines. Amongst those cytokines, there are really 3 key cytokines that I wanted to highlight for you. And the reason being will become far more evident later on in the webinar. But predominantly, you can see here that IL-5, so interleukin 5, is produced, and that is a very key cytokine in the maturation, the proliferation, and the propagation of eosinophils. So they directly impact the activity and movement of eosinophils. Interleukin 13, as you can see down here and up here, is another cytokine that has receptors in numerous parts of the airway, including the airway smooth muscle, but also upregulates production of exhaled nitric oxide and facilitates that. And then the third cytokine is IL-4, so interleukin 4, which amongst other things is involved in facilitating class switching of antibodies that are produced by B cells, so that there is more production thereafter of IgE cells, and these IgE antibodies would go ahead and bind to mast cells, where mast cells degranulate and release all the histamine and all the leukotrienes they contain with them, which leads to the edema, the bronchoconstriction and inflammation that was typically seen in allergic asthma. So initially the understanding was very much focused around mast cells, and then that grew to a better understanding of eosinophils, and all of this is as a consequence of these cytokines. Now, only a few decades ago, we appreciated that there is in fact a non-allergic pathway that involves these cells here in red, and these are innate lymphoid type 2 cells. And these cells, independent of allergen exposure, can and do produce the same cytokines that you can see in the allergic pathway. So what that means is that you can get patients who have no history of allergies or no history of childhood allergies or childhood asthma that develop adult onset or late onset asthma, and that's predominantly driven by the activity of these cells. And as you can see, it's the same cytokines that we initially spoke about. So as a collective umbrella term, this is what we mean by type 2 high or type 2 asthma. And it's these processes or these pathways that are upregulated and activated that lead to the manifestation of the symptoms of chest tightness, shortness of breath, and essentially attacks of asthma within the airways. Now, the majority of patients with severe asthma have type 2 high airways inflammation or type 2 high asthma. A very small minority have type 2 low, and these, as you can see on the right, are very much driven by other cytokines like IL-17R, and this is a pathway that we don't really have any particularly good targets for, or in fact a detailed understanding as much as we have about the type 2 high pathway. And the final thing to add is that, again, over the last 5 or 10 years, our understanding of the components of the airway that are involved in the manifestations of asthma has also grown, whereby we also appreciate now that the airway epithelium itself, which is the cells in gray up here, are also quite an active component of within a patient with asthma or severe asthma, whereby the epithelium, when it is insulted by allergens, smoke, pollution, viruses, it's in itself produces a range of cytokines, including a group of cytokines that you can see here called alarmins. And these alarmins are composed of interleukin 33, interleukin 25, and TSLP. TSLP stands for thymic stromal lymphopoietin, and these in and of themselves can also stimulate and activate various cells within the immune system, including type 2 helper cells, to start producing those exact same 3 cytokines that I mentioned before of IL-4, IL-5, and IL-13. So this is just a snapshot of where our understanding has come to and what's developed. And I think this will become a little bit more relevant when I talk to you about the biologic therapies that we have available for patients with this type of type 2 high asthma. Now, as much as we understand that inflammation is going on within the airways, the real question here is, how can we see this inflammation? How does this manifest? Is it enough to rely on a patient's symptoms to reflect the inflammation? And I think that was answered quite nicely by Pranav Halder and colleagues up in Leicester when they did this work quite some time ago now, looking at whether you take patients from primary care and secondary care and assess whether they have symptoms that are concordant with the inflammation that they generate within the airway. So all those pathways that we saw in the previous slide, does the inflammation in those pathways correlate with patient symptoms? And in fact, it was only about 50% of patients that had concordance between the inflammation that we can test for and see objectively and the symptoms. So that means that there is a group of patients who have a high burden of symptoms, but actually don't have much in the way of inflammation within their airways, which would mean that they don't have significant asthma as their driver for their symptoms. And there are other patients on the other end of the spectrum who actually have a significant amount of inflammation that we can sense in blood tests and breath tests, but actually don't have a number of symptoms. And those patients I would be particularly worried about, because ultimately they could be undergoing perpetual damage or could be uncontrolled and have a high risk for something more untoward, such as asthma attacks occurring further down the line. Now, another way to perceive this was really highlighted by work that was done slightly earlier by the same group, really, led by Ruth Green, where patients with asthma had their sputum eosinophils measured. So they took a group of 74 patients with asthma. Half of the patients they managed as per regular guidelines at the time. And as I'm sure you'll be familiar with, the guidelines really have this step ladder based approach at that time, whereby patients would be started on a low dose inhaler, then stepped up to a medium dose if their symptoms weren't controlled. So very much a symptom based strategy. And the other half of the patients were purely managed based on how much inflammation they had in their sputum. So specifically what the sputum eosinophil count was in those patients. And what we can understand by that study was really quite interesting. So to tell you more details about that, the patients that had sputum eosinophils of 3% or greater had an increase in their inhalers, so a higher amount of inhaled corticosteroid. Patients that had a sputum eosinophil count of 1% or lower had a reduction in their inhaler, so less inhaled corticosteroid, and those patients that were between 1 and 3% had no changes made to their inhalers. So these patients were managed for a year, and as you can see on the right, it's fascinating to see the difference between the dashed lines, who are patients that were managed based on how much sputum eosinophilia they had and titration of their inhalers based on that, and versus those patients that had purely symptom-based treatment and management. And just look at the difference in the exacerbations. There were far fewer exacerbations in patients that were managed based on inflammation, and therefore there was far less oral corticosteroid use and exposure in patients who are managed based on inflammation. Now, the difficult part here is obviously that we can't measure or can't easily measure sputum eosinophils in clinical practice, and certainly not in primary care or easily in secondary care. And most hospitals also can't really facilitate that measurement. So the point here is not so much that we all should keep measuring sputum eosinophils, because that's not quite practical, but the point here being that inflammation targeted management of asthma leads to far less oral corticosteroid requirement and actually better control. So what can we use as a surrogate? Fortunately, blood serum eosinophil counts actually are a really good reflection of the airway eosinophil burden in patients with asthma. It's not perfect, because we know that no test really is. But if we look at some of the studies that have been done where we can see receiver operating curve values of around 0.81, when you try to correlate sputum and blood eosinophils, that's quite reasonable. And here you can see on the left, again, data that was done across more than 25 to 30,000 patients, looking at blood eosinophil counts and how they correlate with the risk of exacerbation on the left, which you can see broken up by deciles. So as the blood eosinophil count starts to rise, you can see quite clearly that the risk of exacerbation significantly increases, and you can also see that the asthma control inversely changes also. Now, one thing to highlight with this is that the blood eosinophil count, when you look at your blood eosinophil count, the normal range that's usually depicted is somewhere between 0 and 500 cells per microliter, or 0 and 0.5. Now, as you can see in this box on the red, these patients are still at higher risk once they go above 300 cells per microliter. So it's very important for all patients with asthma, and specifically with those with severe asthma, to have blood eosinophil counts available and looked at, because they won't necessarily be showing up in your electronic healthcare record system with a red arrow or an H signal to signify the results are high or abnormal. So all patients with asthma, the habit really must be that their blood eosinophil counts are looked at and measured as well. And to hammer this point home more profoundly in patients with severe asthma, here we can see how baseline biomarkers correlate with risk of exacerbation. So what we mean by that is that if you look at the x-axis here, these were all patients that had moderate to severe asthma. On the x-axis was their FeNO when they started the study. And this study was actually a severe asthma study done in patients on a biologic called dupilumab, however, which is the green line here. However, the point of this graph is really for you to take your eyes and look over to the black line, which is all those patients that were in the placebo arm. So patients that did not receive any therapy. So if you follow a patient with severe asthma who does not receive any biologic therapy over a year, you can see that if they start with higher FeNO levels, their chances of exacerbation are much higher and they have a higher rate of annualized exacerbations. And the same can be seen for another severe asthma study done with a biologic called benralizumab in the pink group here, but actually the point of this graph is to look at the gray zone up here and identify that as the blood eosinophil count rose in their baseline, so did their annualized exacerbation rate. And so it's very clear here that the two biomarkers that signify risk of exacerbation that can be measured quite easily at the bedside are blood eosinophils and exhaled nitric oxide. And they are objective markers that demonstrate inflammation and not symptoms. The risk of going by symptoms can be understood by looking at data that's been around for quite some time. And here you can see that there was that over only a third of patients who present with acute asthma had symptoms less than once a week in the 3 months before their attack. And when we take that further, there's a large proportion of patients who passed away from asthma that didn't actually have many symptoms in the 3 months before their severe life-threatening attacks. And we know that the triggers for asthma can be very variable and difficult to predict. However, that's why the terminology of mild asthma really doesn't hold true, because what we should really be looking at is the amount of inflammation, which gives us a direct measure of how concerned and how high risk someone with severe asthma is. So with that, I hope I've given you a sense of what we mean when we say when we talk about a patient with severe asthma, who is essentially somebody that has breakthrough amounts of inflammation with upregulation of eosinophils, cytokines, and still continues to have bursts of steroids or requiring maintenance steroids, and also succumbs to this unfortunate consequences of being in that position. So moving on then, who should we be referring and when really do we refer? I think the recent BTS sign guidelines that came out through NICE as well really helped make this very clear. And as you can see in this diagram, once patients are on moderate maintenance and reliever therapy, if they still remain uncontrolled, and if you have a raised FeNO or a blood eosinophil count, those patients automatically should be getting referred. So we have a very clear direction and streamline of what needs to be done when patients are not responding or continue to demonstrate evidence of inflammation, type 2 inflammation, despite being on moderate dose MART therapy. And those are the patients that should be referred. If we really delve into this further and look at a nice UK Delphi study, consensus study that was published a few years ago, this was a study done by surveying, receiving questionnaires from over 100 clinicians who are specialists in asthma, including nurses, pharmacists, even patients, who came to a very strong consensus here about the types of patients that you should be referring. And as you can see here, that anyone with asthma, and remember, these are patients who are adherent to the inhalers, taking the inhalers properly and using them in the right manner, but anyone who's had 3 or more courses of oral corticosteroids in a 12-month period should automatically be referred, and that's obviously with a strong 97% consensus. And then here with 100%, anyone who's on maintenance oral corticosteroids, specifically from asthma, should always be referred into a specialist asthma service. Now, you may remember that I previously told you that the definition of severe asthma was someone who was on high-dose inhaled corticosteroid therapy with a second reliever, but had also had only 2 or more courses of steroids in a 12-month period. However, given the NICE criteria for access to biologics in the UK, this number sits at 3, which is very different to other countries. The other thing, however, is that it's not just courses of steroids that will allow you to refer someone in. There are some expectations that we would want from colleagues to ensure that patients must be adhering to their inhaled corticosteroids, because the fundamentals still remain of crucial importance. And there have been a number of patients that were referred even to our tertiary severe asthma service who, after optimization of their inhalers, are far better and actually do not require any further input from our specialist team, and actually just simply needed to take their inhaler in the right manner and in the right strength. So those things also need to be optimized prior to referral. And for those of you who are unsure as to kind of what high dose inhaled corticosteroids labor inhalers look like, Right Breathe is a very nice resource. I'm sure there are others available, but I find it quite helpful because you can see that you can differentiate which inhalers are considered high dose inhaled corticosteroids. Now, there's some slight confusion because the new NICE BTS sign guidelines have essentially said that when patients are already maximized on moderate MART therapy, they should automatically be referred in. Now, in order to be considered eligible for asthma add-on biologic therapies, patients must be on high-dose inhaled corticosteroids and a second reliever. So therefore, it may be more helpful in certain circumstances to actually prescribe a high-dose inhaled corticosteroid simultaneously when you refer the patient in, so that when the patient does get referred into a severe asthma service, there is not time wasted around trying to optimize their inhalers before being able to access any necessary add-on therapies. So those were the dry powder inhalers, and these are the MDI inhalers, all of which are high-dose or considered high-dose inhaled corticosteroids. One of the points I wanted to make was that there are only 2 available high-dose triple inhalers, so triple meaning ICS, LABA, and LAMA therapy. The reason I'm making a point about this is that sometimes inadvertently, in order to prescribe or provide the patient with a triple inhaler, I often find that patients have been actually reduced from their high dose inhaled corticosteroid and LABA to a moderate dose ICS, LAMA, LABA. So just be mindful, if you are going to be referring the patients to a severe asthma service and you want to change them to a triple combined inhaler, it has to be one of these 2 inhalers. And the other point is that if you do end up prescribing any of the inhalers on the left here, they are all medium dose ICS and therefore would not be considered eligible for consideration of add-on biologic therapies at this juncture. Now, hopefully that gives you a perception as to who you should be referring. And ultimately, what we really want to demonstrate to you is why should you refer? And the reason is because we now have options. Up until a decade ago, there really weren't many. What you can see on this diagram is that we've had steroids and cortisones discovered in the late 1940s, and we had inhaled corticosteroids since 1973. And we've been learning about different cytokines within the airway, which I demonstrated to you earlier, that actually now have targets for. So you can see color-coded matched drugs that target those pathways within the airways of patients with severe asthma, which can block the inflammation that's being driven by these pathways and actually lead to incredibly favorable outcomes without the known side effects of oral corticosteroids that I demonstrated to you earlier. Now, if I know this is the same image that I showed you earlier, but just to demonstrate where these biologic injections work, the first ever biologic that we really had access to was nearly over 20 years ago, and this was omalizumab. And the way omalizumab works is actually by binding to IgE antibodies. And by binding to the Fc portion of the IgE antibodies, you prevent the IgE antibodies binding to mast cells and therefore activating the mast cells to degranulate, which reduces the symptoms in allergic asthma patients. And this works very well in the childhood onset population, and it is dosed based on weight and requires patients to have sensitivity to perennial, so all year round allergens. The other biologic that came a little bit later on was mepolizumab and reslizumab, and mepolizumab is an anti-IL-5, and so is reslizumab, but mepolizumab is subcutaneous and reslizumab is the only intravenous asthma biologic. So as you can see here, it blocks interleukin-5, and as you'll remember, interleukin-5 is a key critical cytokine in the maturation, the development, proliferation, and propagation of eosinophils. So once you block the signaling via IL-5, you will naturally have less eosinophils and less activity of eosinophils. So this blockade has been shown and proven to be quite helpful in dampening that. A year or so later, we had the next biologic in the anti-eosinophil space, which was benralizumab, and benralizumab works slightly differently because it actually binds to the IL-5 receptor alpha that is present on eosinophils, and in fact recruits natural killer cells from your own immune system to destroy the eosinophils. So in fact, benralizumab depletes and destroys eosinophils quite potently, whereas mepolizumab, reslizumab deplete and reduce eosinophils quite significantly. The next biologic that came along was dupilumab, and some of you may have heard of dupilumab in the dermatology space, where it has been used for atopic dermatitis for a number of years. And this biologic blocks IL-4 and IL-13, so the other two cytokines that we spoke of earlier. And by blockade of those two cytokines, we can naturally expect and do see the reduction in asthma attacks and inflammation within the airways. And then finally, the most recent biologic that we have available as of this moment in time is tezepelumab, and tezepelumab works by blocking TSLP, which stands again for thymic stromal lymphoprotein, which is one of the cytokines, one of the alarmins that is released from the airway epithelium when there is an insult encountered by the airway epithelial cells. So these are the options. They're all subcutaneous except for reslizumab here, which is intravenous, and they all have dosing schedules between 2 to 4 to 8 weeks. Now, just for interest purposes, I've just listed the NICE criteria. So those of you who are based in the UK will see why we have certain criteria that we must satisfy in order to commence patients on biologics. And you can see that the minimum requirement is 3 courses of oral corticosteroids with varying degrees of blood eosinophil counts within the last 12 months, or maintenance oral corticosteroid requirement. Now, historically, access to asthma and biologic therapies has been through severe asthma centres, through national commissioning, and that was predominantly because to ensure a high standard of asthma care, severe asthma care is delivered to patients, but also because of the high cost of these drugs, and also the understandable need for these drugs to be continued almost endlessly for a lifetime. And therefore, this was the general structure. However, in more recent times, there is certainly a trend towards more localized or ICB level commissioning of these medications, and I think the future will very much be in the hands of ICBs to that degree. Now, just to demonstrate the efficacy of these biologics, I've just got 2 real-world studies. So these are not the randomized control studies. These are done in real-world settings in multinational studies. So here on the left, you can see when you look at over 800 patients that were started on the mepolizumab biologic, after a year of therapy, there was a 74% reduction in exacerbations, which is rather profound, I'm sure you'll agree. And the same is something that we saw in the UK severe asthma registry as well, whereby patients went from a baseline of requiring 5 courses of steroids within 12 years down to just 1 in the space of just a year of being on benralizumab, and that also was also demonstrated in their reduction in the asthma control scores, which is a positive thing. And I can't really stress how life-changing these are, because that's the same term that we hear from our patients, and they're incredibly effective even outside of clinical trials and randomized control studies, and in fact more effective in the real world setting than in randomized controlled placebo studies. Now, the beginning of this subsection, I mentioned the question of why we need to refer, and some of that is hopefully visible here when we really look at a breakdown of the timelines that was gathered from anonymized data collected on about 400 patients over the span of 2019 and 2020 from 17 different asthma centres. And here you can see that patients with severe asthma spend an incredibly long amount of time being uncontrolled before they're referred in. And it's really quite sad to see that level of despair, because that's what happens when they finally come to severe asthma centres. They're already almost broken. They certainly have developed all the terrible side effects from oral corticosteroids and are essentially quite defeated in their asthma journey. So there is certainly room to improve that. And even after they do get referred to the specialist centre, it doesn't automatically mean that they can get onto the appropriate therapies or have the appropriate treatments, because it does take time for the referrals to be processed, and it does take time for a discussion to be had at MDT. So this entire journey is extremely excruciating for patients, and certainly something, a reason why they should be referred in a timely fashion. And specifically looking at the UK population, there was data gathered from both the UK patients that went into the International Severe Asthma Registry and patients that were in primary care databases. You can see that the patients with potential severe asthma who are above the age of 16, and potential severe asthma in this study was defined as with the ATS and ERS criteria, the patients who have had 2 or more courses of steroids in a 12-month period despite being on moderate to severe high dose inhaled corticosteroids. You can see that 8% of patients were those who had potential severe asthma, but out of those patients, only a quarter of patients were ever reviewed or referred. So there are still a vast majority of the patients who hadn't even been referred. So you could see how there are a number of failings going across the care platform. And to look at this more broadly, the biologic penetration across England is extremely poor as well, whereby we only are actually getting to about somewhere between 20, maybe 25% of the patients, and in some areas even fewer, down to 8%. So we've got therapies that can change the lives of these patients and can alleviate their symptoms, but we really haven't been able to get them get the majority of patients the therapies they need, and that really falls upon us to really understand how to refer them and why to refer them. So there really isn't any need or value in waiting for all these conditions to start to creep up and develop. And I often find myself asking myself, I wish I could have just seen this patient sooner. I wish I could have just seen this patient earlier, so that we could have prevented them becoming remodeled and damaged and actually psychologically impacted. Because the thing that often gets overlooked is the detrimental effects that happen on their personal lives, how that changes their interactions with their family, how that depletes their ability to work and therefore lose income and have to go on to benefits. And so all of this is very much a consequence of severe asthma that can be avoided. Another way of looking at this has really come to light within the past few years, where we've been talking about remission in asthma. And what this was a study from the UK Severe Asthma Registry of over 830 patients, and specifically looking at what factors are responsible for the chances of achieving remission. Another way of saying that are, what are the features that lead to a lower chance of achieving remission? And we know that obesity or a high BMI can interfere with your chances of achieving remission when you go on to severe asthma therapies. And for every kilogram per meter squared increase, there was a 5% less likely chance of achieving remission. The longer you have your condition of severe asthma, the lower the likelihood of you achieving remission. And so if you've had asthma for more than, or severe asthma for over 10 years, you're going to have a lower likelihood of achieving remission. And the more symptoms you have when you are started on asthma therapy, the less likely you are to achieve remission. And if you've got interference with your mental health and psychiatric conditions, that also reduces the chances. And if you have low levels of inflammation, which is the type 2 low category that I described earlier, those also are features that reduce your chances of achieving remission. So the message very much leans towards timely referral of the right patients who are refractory to their high dose inhaled corticosteroid and second reliever. So what about these agents and treatments? How is it that we manage these patients with severe asthma who have started on their biologic injections? And I'm sure over the years, you will all come across patients on these biologics, and therefore I hope you'll find some practical use or some insights in the next few slides. What you can see here is what we routinely do for patients with severe asthma. So once they're commenced on the appropriate biologic, they essentially have 6 monthly reviews within a consultant-led clinic, and alongside that they will have asthma nurse specialist reviews potentially every few months, just to check in and ensure that their treatment is going well and that they're obviously adhering to it and using it appropriately. Once stable and once we see that a patient is responding well, in fact, the reality is that they don't necessarily need more frequent reviews, and they can be seen annually with lung function and biomarkers. So that's our typical approach. And the beauty of asthma biologics is that they have absolutely no interference with renal function, liver function, or any significant amounts of the immune system, and therefore no routine monitoring needs to happen. So actually they're quite benign and easy to use in that fashion, where you don't have to measure drug levels, you don't have to measure renal or liver function or monitor anything in particular at all, apart from the initial stages and also the lung function and blood eosinophil counts. We actually, you might be wondering kind of what happens if the biologic doesn't work and how often we stop and switch. And I think it was depicted, what we initially do is a 6-month review. So after the patient's been on biologic for 6 months, we ask the question, have they responded? And response is typically measured as at least a 50% reduction or more in their maintenance oral corticosteroid if they're on maintenance, or a reduction in the number of courses they've had. So we always need to know what their pre-biologic exacerbation or oral corticosteroid burden is, so that we can then compare it at the 6-month mark. And that can extend out to 12 months as well in some circumstances. And nice really have a strict cutoff at 12 months for monitoring or measuring response. And I think that one of the key things that is important whenever we think of patients not responding or potentially not responding is to measure biomarkers when they exacerbate. So in your hands in primary or secondary care, if you do come across these patients, please do try or take every endeavor to capture blood eosinophils, exhaled nitric oxide, and spirometry if available, prior to prescribing further courses of oral corticosteroids. Because what we've learned from various exacerbation studies, such as the MEC studies and the BENREC studies, is that if patients have high phenos during times of exacerbations, those are the patients that will respond to oral corticosteroids, and actually that tends to be a smaller proportion, and there seems to be a larger proportion of patients that actually just need potentially antibiotics if they have the clinical symptoms to match. So it's incredibly imperative that we learn what is still active in terms of inflammation when these patients exacerbate. And you can see here that 80% of the time we actually get it right. So the majority of patients that we start on a biologic actually continue, and it's only about 20%, which you can see from the Chronicle database from the US and the International Severe Asthma Registry, which is obviously in combination giving us a large population of about 10,000 patients. We do a rather good job, and I think this reflects quite evenly across severe asthma centres in the UK, where about 80% of the patients do respond to the initial biologic that they were placed on. The other question that you may have is, what do you do about their inhalers? Now, this was answered in some way, or at least in the initial phase of trying to answer that question. We had the Shamal study that was published last year, and here we saw that patients who are on benralizumab, over 90% of those patients could actually reduce their inhaler quite significantly. So no longer do they need to remain on high dose inhaled corticosteroids, but in fact they can be reduced all the way down to low dose, and a lot of them you can see on anti-reliever inflammatory therapy. The downside of that was that when you look at patients who were reduced to the reliever only arm in the kind of light green down here, those patients seemed to have a reduction in their lung function. So their FEV1 went down, and those same patients seem to have a rise in their exhaled nitric oxide. So one of the things that would have been helpful is obviously if we had a longer study to see what the trajectory of these lines would have been. But for that reason, we very much take the view that patients should be and will need to be on some form of inhaler therapy, but not high dose inhaled corticosteroid therapy, if of course they have started to respond to their biologic. And this study was done in benralizumab, but I'm aware that other studies are expected with the other biologics. And I think that makes entire sense, because we know that the actual maximum clinical efficacy of inhalers really is between the low and medium dose range, because you can see that there's not much of an increment between medium and high dose inhaled steroids. And in fact, all we really end up doing to patients that we move from medium to high dose is exposing them to more systemic side effects from steroids. And here you can see how that plays out. The other kind of patient population that that you may come across on biologics would be patients who are pregnant. Now, we don't have particularly strong data in all the other biologics besides omalizumab. So omalizumab is the only one that has a registry, the REACT registry, that demonstrated safety and no change or increase in side effects or to both the fetus and the mother when taking omalizumab. There are other registries open for the other biologics, because in all the phase 3 randomized control studies, pregnant patients were obviously excluded. But that being said, the approach to pregnant patients is very much in line with the recent Delphi consensus that was published, which really means a risk-benefit discussion occurs with the patient, and it was more of a shared decision making. We tend to explain to patients and expectant mothers and their families that the data isn't there. However, uncontrolled asthma during pregnancy is also detrimental to the unborn child, and thus the priority really needs to be around maintaining asthma control even during pregnancy. The other convenience with asthma biologics, because they're all, majority of them available in self-administrating pens, are that they are administered at home, and patients are easily taught how to do that. They do require refrigeration, and even some of the more recent biologics can actually be kept out for about 30 days, so it's not too difficult to travel with them. But obviously between that time, they must be kept at the right temperature. As I said, they can be administered by patients themselves within the stomach or the thighs, but if they're given by someone else, then the arms are also a possible area. These are all subcutaneous, so there's no intramuscular element. And the majority of patients tolerate them incredibly well. The most common things you can see listed here are what patients tell us, but really speaking, a lot of these kind of tend to fade over time as well. So no permanent damaging side effects that we've come across, at least. And you can see that when you look across at the various biologics, we know things have been reported in literature, such as anaphylaxis with omalizumab and rezumab, but I can honestly say that we've never really seen genuine anaphylaxis with any of the biologics at all. Mepolizumab and dupilumab have some reports of associations, but not causations with shingles. Dupilumab and also tezepelumab can lead to some ocular symptoms of conjunctivitis, and we also hear about arthralgias and arthritis in some patients. But again, these biologics, as I said to you, are between 2 and 8 weekly in their administration. So typically, if you stop, and when you stop the biologic, any associated side effects from the biologic would also fade over the ensuing months. The other thing to mention is patients often are concerned about the fact that these biologics have really only been around for a decade, and therefore are there risks or untoward side effects that would be expected in the longer term. Now, because we don't have more than 10 years worth of data, all I can say is that there are global registries that have been monitoring for this, and to date there is no such concern that's been highlighted or that would make us worried about doing this. And in terms of active malignancy, we know that the patients who were within 5 years of malignancy were excluded from the randomized control studies. So we very much need to take a case-by-case view and potentially need to discuss cases with patients individually and their oncologists to, again, demonstrate, similarly to pregnancy where we don't have the data, but may actually be more fruitful for them to have a risk-benefit discussion and potentially continue their biologic. The other thing to mention is patients that have kind of high-dose chemotherapy or broader-acting chemotherapy that have immunosuppressive properties tend to actually have a curative effect for their asthma, because you're wiping out their inflammatory milieu in their cells. So those patients don't tend to need add-on biologics, but it all depends on what therapies they're going on to. And the other thing that I wanted to mention was something that I get asked about almost on a weekly basis from colleagues, whereby patients are about to have surgical procedures, and because in rheumatology, dermatology, gastroenterology, the biologics they use in that space tend to be far more broadly immunosuppressive, and they have influences on poor wound healing and recovery, and therefore those biologics are typically withheld in the peri, post, or preoperative period, whereas asthma biologics do not need to undergo such treatment because they do not broadly interfere with those elements such as wound healing or perioperative outcomes, and in fact would probably benefit patients having better control going under general anesthesia with a biologic, asthma biologic in their system. So with that, I just thought I'd wanted to highlight a few of the summary points, which hopefully have been well made, in the sense that we have now a plethora of phenomenal options for patients with severe asthma, and I'm talking genuine severe asthma who are refractory to their inhaled therapy and on the right inhaler with the right technique. And so we shouldn't, and you shouldn't really ever see or come across a patient on maintenance oral corticosteroid without referring them on for a severe asthma service. The treatments that we do have available are incredibly well tolerated, and I can't explain how many times a week we hear such favorable responses from our patients. And that being said, we still have work to do because we're only really up to 20% penetration or biopenetration of patients with on biologics. So there's still a very vast majority of patients who would and could benefit from asthma biologic therapies that we need to keep referring in for. And we have such a fortunate position to be able to offer these therapies because there are a number of countries where these biologics are incredibly expensive and have to be paid out of pocket or not even offered to patients. So with that, I thank you very much for your attention, and I hope this is very useful. Thank you.